Great. Thanks so much, Kelly. And please, everyone should call me Larry. Very informal. The other thing I would mention is that because I'm in presentation mode, I can't see a lot of people. So I can't tell if people are trying to speak. So you should just shout out or whatever. If you want to interrupt me, that would be fine. I just can't see you on the screen very well. So I wanted to tell you a story about some work that we have done in Rwanda. I went to Rwanda a little over a decade ago, together with Paul Farmer and Partners in Health. And at the time that we got there, there was not a single oncologist in the country. There was basically no cancer care in the country. And we set up a cancer center in northern rural Rwanda at Butaro Hospital, which now 11 years later is providing about 90% of the cancer care in the country. And in that time, we've seen roughly 17,000 patients. So it's a busy center, even though it's in rural northern part of the country. But we've set up a program where we try to treat as effectively as possible the diseases that we think we can impact on. And I'm going to tell you a story about one of those diseases, which is Hodgkin lymphoma. I will tell you that early on in our work there, my colleagues in Rwanda and I wrote and published this article in the Journal of Clinical Oncology on implementation science for global oncology. And we said that it was an imperative to evaluate the safety and the efficacy of cancer care delivery. We were delivering cancer care in a place that was quite unusual, very resource constrained. And we wanted to make sure, in fact, that we were doing well by our patients and that we knew, in fact, how they were doing. I will say that we've done very little of this in the US. We assume we're doing great in the US, but when we do look at it, sometimes we're not doing as well as we should. So this is really something, frankly, that should be done everywhere. All programs should be introspective to make sure that they're providing safe and effective care. But there are some specific things about cancer care in a place like Rwanda. The treatments that I'll describe to you for Hodgkin lymphoma were developed in the US and in Italy. Largely, the studies were focused on white Caucasian patients. So, there are some questions that we wanted to answer in our study. One is, could we effectively and safely treat cancer patients at Butaro Hospital? But we also wanted to know whether the patient's cancers would respond in similar ways to treatment compared to US patients. And we know in a number of different diseases that the diseases from a genomic point of view are different in different ethnic populations. So I don't think that we can assume that the treatment that works for a white Caucasian in the US is also going to work for a Rwandan. And there are very good examples of this in lung cancer, for instance, which is genomically different in Asia than it is in the US, and so on and so forth. And I'm going to show you some factors about Hodgkin's disease in Rwanda that suggest that it is, in fact, a different disease. In addition, as you know, we're all born with germline polymorphisms that determine how we metabolize drugs. For caffeine, some of us are fast metabolizers, some of us are slow metabolizers. We know that for drugs like Coumadin, there are patients who metabolize it differently. And we don't know whether the polymorphisms that are common in our Rwandan colleagues will cause them to metabolize the chemotherapy drugs in the same way that white Caucasians do. And we've had a number of examples where, in fact, it is different, and the drug may not be effective because metabolism is faster, or it may be more toxic because metabolism is slower. So again, we can't assume that the toxicity profiles of the therapies that we're using would be the same. There are some specific benefits of implementation science. First and foremost, it allows us to analyze what we're doing and ultimately to find out where the gaps in care are and to improve the care for our cancer patients. But it's also important, particularly for places like Rwanda, to prove to the governments and international organizations and NGOs that we in fact can provide safe and effective cancer care in very resource-constrained settings. And frankly, many people in the world have felt that we can't do that and we shouldn't even try. And I think we proved with Hodgkin's and other diseases that we can, and also to prove to funders that it's worth supporting cancer care in places like Rwanda. So for implementation, what are the challenges? We need to ask ourselves for any particular disease or treatment, what are the questions that we want to answer? And I'm going to go through with you with the Hodgkin's story, some of the questions that we had that we did answer through that study. But going forward, going into one of these studies, you need to think about what it is you're worried about, what it is you want to explore, what it is you want to answer in the study. You need staff leaders, and really at all levels, physicians, nurses, students, research assistants, and research directors. And we had all of those people in Rwanda. We had a physician leader, we had a nurse research leader, we've had students primarily from Penn and from Dana-Farber at Harvard who have traveled over there. And frankly, they do a lot of the research work. They do a lot of the chart abstraction because our doctors on the wards are very, very busy. And it's a great experience for them, and it helps us. We have research assistants who track down patients, get follow-up on patients, and we have a research director who is skilled in methods of study and biostatistics who can help us to analyze the data. So it's a team approach. No one person is doing this work, and frankly, it's fun to work as a team. And most rewarding. And when I show you the paper, you'll see all the members of the team who are authors on the paper, and it's a large group. You need enough patients. If you don't have enough patients to study, you're not going to be able to answer the questions. And when we published this study, we had 85 Hodgkin's patients, which is really enough to help us to start to understand what we've accomplished, what the patients are like, and so on. And you also need consistent treatments. If every patient gets a different treatment, you're not going to be able to study the effects of a particular treatment in a population of patients. And we've tried very hard for not just Hodgkin lymphoma, but for all the diseases that we treat in Rwanda to have a very consistent approach. We have written down pathways for a patient with disease X, they get treatment Y, and so on. And so our treatments are very consistent. And basically for all the patients with Hodgkin lymphoma who came to Pitaro, they all got the same treatment, ABVD, which I'll talk about in a little while. And then obviously you need data. And from the very beginning, we prospectively accrued data so that we know the patient's age, gender, we know what their performance status was at the beginning of treatment, what their stage was, and we have all the data about the treatment that they received. And I'll go through some of those data, but you can't recover data often that you don't have from the beginning. And so we've had data sheets that the clinicians fill out on our patients going forward. They're stored either electronically or in paper copies. And so we have all the data that we need. It's not perfect. Sometimes there are missing elements, but mostly we've had pretty good data. And that was a commitment we made from the day that we opened the Cancer Center in 2012. I think that's really critical. So a little bit about Hodgkin lymphoma, and I'm sure you're all very familiar with this disease, but just to remind you, it occurs primarily in the US in young adults. The average age for a patient in the US is 26. That's pretty typical young adults. We see some older patients, some younger patients, but most of the patients are in their late teens. 20s and early 30s. Most of the patients initially present with lymphadenopathy above the diaphragm, often in the neck or the mediastinum, and they often have a mediastinal mass. Sometimes that can be quite bulky, which makes the prognosis not quite as good. Hodgkin's is a disease that was very exciting to a lot of us. I'm a really old guy, as you can see. And I went to medical school in 1971, and that was really at the beginning of oncology. It was when we were just starting to learn to use chemotherapy. And a few years before, at the National Cancer Institute, they used a regimen called MOP, which was nitrogen mustard and Crystine, procarbazine, and prednisone, to treat Hodgkin's patients. And for the first time, we could cure Hodgkin's patients even if they had relatively advanced disease. And this was like a miracle to us. You need to understand that before this, basically, those patients came in, you gave them a hug, you sent them home, and they died. And you had nothing to offer them. So, you take it for granted that we have combination systemic chemotherapy, but this was really the very beginning of it. Hodgkin's was one of our first examples of success, but it was an extremely toxic treatment. It had a lot of immediate toxicity, had loss of fertility, and remember, these are largely young adults. And a fair number of the patients developed acute leukemia, which was related primarily to the nitrogen mustard and procarbazine. So 20 years later, actually coming out of Italy, there was a regimen called ABVD, which included doxorubicin, bleomycin, vinblastine, and dacarbazine. That was really a major advance. It didn't cause leukemia. It didn't cause infertility in most of our patients. And now, 40 years later, it's actually still the treatment of choice for Hodgkin lymphoma. We've tried a bunch of different regimens over the years. I actually have some publications from the 90s where we tried alternatives to this regimen. None of them were better than this. There are now some new immunotherapies that we're using, but basically, if you came to Penn with early stage Hodgkin's disease, ABVD would be likely what you would receive. So it's a good regimen. And in the US, about 85% of the patients who get ABVD have long-term remissions. So it's a pretty effective therapy. The role of radiation is evolving. We used radiation very extensively in the 60s, 70s, and 80s. We still use it a fair amount. But it's turned out that radiation has very severe long-term complications, including cardiac complications, pulmonary complications, second malignancies. Women who receive chest radiation at a young age have a very high risk of developing breast cancer, for instance. And I have a survivorship clinic here at Penn that has a lot of Hodgkin's patients. My longest survivor was treated with radiation in 1968. And she's got all kinds of complications from the radiation. So we're using radiation less now than we used to use it, but it's still an important part of treatment. I will say that during the study that I'm going to show you, radiation was not available in Rwanda, and so none of our patients got radiation. So that's important to know right from the start. So some of the questions that we asked ourselves when we were starting the treatment was, what are the demographics of our Hodgkin's patients in Rwanda? Are they similar to Caucasians in the US or different? Could we make an accurate diagnosis? It's not that easy a diagnosis to make, and I'll talk a little bit about that. Could we deliver chemotherapy at full dose and on schedule? And we know from US experience and experience elsewhere that if you don't give the chemotherapy at full dose and on schedule, the likelihood of curing the patient goes way down. And I'm going to show you those data from our experience in Rwanda. And obviously, ultimately, what's important is how did our patients do with good follow-up. So this is the paper that we published in 2020. It was a little bit delayed because of the pandemic, But you can see, first of all, that there are a lot of authors. Becky DeBoer, who's the first author, did this work when she was training as an oncology fellow at UCSF. She's now a faculty member there and still involved in our program. The second author, Cyprian, is the director of our cancer program at Bataro. He's a Rwandan. Caitlin Driscoll is one of our research directors. She actually is no longer there. She's now in medical school. But before going to medical school, she was our research director, and so on and so forth. So it's a big group. Below Becky's name is Deo, and he's our pathologist. So a lot of people are involved, including the nursing staff. This was a group effort, and our conclusion was that treating Hodgkin lymphoma with standard chemotherapy in low resource settings is feasible. Most patients who completed treatment experienced clinically significant remissions, but late presentation, treatment abandonment, loss to follow-up, or problems as they are in many low resource settings. So I'm going to tell you a little bit about the study, but again, we set out what our goals were again, and we put this in the manuscript. This is taken out of the publication about how we can approach treatment for curable cancers like Hodgkin's in a place like Rwanda. How can we analyze the 77 patients who we treated there? As noted in that paragraph, there is a 63% 3-year overall survival for our patients. If it were the US, it would be 85%. So we've gotten part way to our goal, but not all the way to our goal. So we know what the gap is. We know how we've done. We know we haven't done as well as we might. So you probably can't read this, and I didn't put it up for you to read, but almost every one of our articles in Implementation Science has a flow sheet like this that tells you what happened to every single patient who came to our cancer center with that diagnosis. So there's no smoke and mirrors, there's nothing hidden. It has the patients who were lost to follow-up, those who died very early on, as complications from therapy or complications from disease, and so on and so forth. So every patient is accounted for in our population one way or another, and very graphically displayed, so that we want to be totally transparent about this. And there are publications that come out of other places that don't include the patients who didn't come back for follow-up, don't include the patients who might have disappeared and maybe died of treatment-related toxicity, we don't know. All the patients are accounted for here one way or another, and I think that's really, really important. Just to be honest with ourselves, most of all, but also to be honest with people who are reading our manuscripts. Just a couple of things. One is that we looked at so-called ECOG performance status. I don't know if you're familiar with this or not, but we use this in the US and elsewhere to better assess the status of the patient when they come in initially. Because we know that patients who are very sick at the time of diagnosis are less likely to do well. That turned out to be true in Rwanda as well. But this is the ECOG performance status scoring. 0 is asymptomatic, 1 is symptomatic but completely ambulatory, 2 symptomatic but less than 50% of the time during the day in bed, 3 is symptomatic and greater than 50% of the time in bed during the day. So those people are pretty sick. And 4 is bedridden. The other thing that's important, and I mentioned this earlier, is to know what the dose intensity was of the chemotherapy that you delivered. And there are 2 factors here. One factor is the actual dose delivered, and the other is the duration of treatment. So if there's a delay in treatment, which is not good, that actually lowers the dose intensity as well. So in a simplistic way, if you had a patient who was supposed to get 100 milligrams of a drug, but only got 80 milligrams, and they got it over 20 weeks instead of 10 weeks, the first part of that equation is 80%, the second part is 50%, the overall dose intensity would be 40%. So both of these factors are taken into account because they're both really critical. And this is the type of formula that we did for all the chemotherapy that was administered to our patients. So these are the demographics of the 85 patients who came to see us. There were a number of patients, 8 patients, I believe, who got treated elsewhere first. And those were not included in the treatment analysis because we did not treat them with our regimen. They got other treatments in other places. But overall, we had 85 patients. One of the striking things was the median age was 16 years. That's 10 years younger than in the US. And I'll show you more data on that. Most of the patients were from Rwanda, as you would expect, but we also see patients from Burundi, the East Congo, and sometimes Uganda, neighboring countries. The stage of patients is shown here. Stage 1 is 1 nodal group. Stage 2 is 2 nodal groups, but on the same side of the diaphragm. Stage 3 is nodal groups on both sides of the diaphragm. And stage 4 is organ involvement like liver, lung, and so on. B symptoms are fevers, night sweats, or weight loss at the time that they first come in, and 70% of our patients had B symptoms, and that goes along with the fact that over 50% of the patients had stage 3 or 4 disease, as you see here, and 25% of the patients had what we would define as bulky disease, usually big mediastinal masses. This looks different than in the US, where many more of the patients would have stage 1 or 2 disease, fewer of the patients would have B symptoms, and fewer of the patients would have bulky disease. This, unfortunately, is the case in many low-resource settings because patients come to care relatively late, or they come into their health centers, and those people working in the health centers don't recognize the fact that they might have a malignancy. We did also look at ECOG performance status, and 2/3 of the patients were asymptomatic, largely, and you can see that relatively few patients had ECOG performance statuses of 3 or 4. So this is the age distribution that we published here, and this is remarkably different than in the US. And you can see that the majority of our Hodgkin's patients were children, and Hodgkin's is a relatively rare disease in children in the US, though we did see another spike, if you will, in the 20s, as we do in the US, in some patients who were older. But this is remarkably different, and we have no idea why this is. We don't understand the etiology of Hodgkin's disease very well. Some people think it's related to Epstein-Barr virus. We actually did look for Epstein-Barr virus in some of our biopsies. But this is something that we need to get to the next level of research in at some point. We need to study genomically what Hodgkin's patients look like in Rwanda versus what they look like in the US. And we've not done that yet. Things got pretty slowed down because of COVID, but we've started up our research now, and hopefully we'll get to look at this. But these are the things you can't assume. You can't assume that the demographic population in a place like Rwanda or Vietnam is going to be the same as it is where a lot of these things have been studied. This is the details of the drug regimen. You're probably all familiar with this, but the doses are here: doxorubicin, bleomycin, vinblastine, and dacarbazine. The regimen is given every 2 weeks for a 28-day cycle, and it's 6 cycles over 24 weeks. So ideally, the patient would get full dose like this every 2 weeks over 24 weeks for 6 cycles. And that's what we consider to be the ideal care. So we looked at some of the quality of treatment metrics. One of the important things was the time from the initial biopsy to the initiation of treatment. And we know from a lot of data that delays in treatment reduce the likelihood of long-term cure and survival. We didn't do terribly well here. The median time from biopsy to treatment was 6 weeks. In the US, it would be much shorter, maybe in Vietnam as well. And so we're now putting into place some changes in the way that we manage these patients so that their treatments will start sooner. We looked at the time from initiation of chemotherapy to completion, and it was about 26 weeks, so it's about 2 weeks longer on average than it ideally would have been. It's not too bad, frankly, but it's not perfect. And the reason for treatment delays are listed in the next box, most commonly neutropenia, but there were also social factors, people who couldn't get back for their next treatment because of transportation issues, a small number of infections. And one of the things that we look at very carefully is stockouts of chemotherapy. And what we know about ABVD is if you didn't use the doxorubicin, the cure rate goes to 0. So you need all 4 medications. And if you're stocking out with any of them, that's not a good thing. And we had conversations with our colleagues there. If they did stock out, was it better to treat them missing one of the drugs, or was it better to delay them until we got all the drugs that we needed? And generally, we delayed them because we wanted them to be treated with all 4 drugs. So we worked very hard to prevent stockouts, but they do sometimes occur. And then finally, dose intensity. We actually did pretty well. We looked at mean and median dose intensity, and both of them were around 90%. That's actually not so different than it is in the US at Penn. We may do a little bit better, but there are things that cause us to either reduce dose or delay treatment. So we were pleased. We need to always try to do better, but overall, we felt like we did pretty well. So these are the patient outcomes, and this is a busy slide, but if you look at the upper left panel, it's survival, overall survival by ECOG performance status. And you can see that the top line is performance status 0. And those patients, as would be expected, do very well. They had about an 80% long-term survival. Those who had a performance status of 1 or 2 did a little less well. That's the red line. And for those patients who had a performance status of 3 or 4, they did dismally. And most of those patients, unfortunately, died within a few weeks. If you look at the panel, upper right panel, that's by stage. And the top line is stage 1 and 2 disease. So you can see that when patients do come in with very early stage disease, that they do very well, that they have about an 85 or 90% long-term survival. That's actually not so different than in the US. So that's pretty good. If you look at stage 3 disease, they're down to about 50%, and stage 4 disease is much worse. So when they come in, we need to figure out ways in the health system to identify them early and bring them in when they have early stage. These data are not that different than in the US, except that for very advanced stage, we do have second-line therapies in the US, like autologous stem cell transplant, which rescues a lot of these people. That's not a therapy that we have available in Rwanda. And in fact, we've not had any second-line therapy. So if they don't do well with their ABVD, we've really had nothing to offer them, unfortunately. If you look at the left lower panel, that's ABVD completion. And you can see if the patient completed all 6 cycles of their ABVD, they tended to do pretty well with about a 70 or 75% long-term survival. And if you look at the lower right panel, it's dose intensity greater than 85% versus less than 85%. And you can see that getting in full dose and on schedule has a major positive impact on how the patients are going to do, just proving again how important that is. So that's my last slide, and we have plenty of time for questions or discussion. Kelly, do you want me to take the slides down, or would you like to leave them up in case we need to go back to them?
Yeah, I think it might be good to leave them up. Just if people have questions, we can go back to a particular slide. So great. Well, thank you for summarizing this really interesting and important study. So let me open up to other people. Anyone have questions about this study in particular in terms of how it was designed, how data was collected, how it was analyzed? Well, I can start off with a few questions while people are thinking. How long did it take to accrue this many patients? And you had mentioned you thought around 80 was enough. Like, how do you know how much is enough to have a reasonable number to be able to draw some conclusions?
So those are great questions, Kelly. So we opened our cancer center in July of 2012. And so it was over really about 7 years that we accumulated the 85 patients. The number is arbitrary. More is always better. It helps us to better understand what's going on. But we did feel like with 80 patients, we were going to be able to show you the data that I did show you about really understanding the age distribution and some of the other characteristics and ultimately how the patients did. If you look at studies in the US, they often have hundreds of patients, so they tend to be larger. But we felt like we had to look and see how our patients were doing. And, it is an arbitrary decision and when to cut it off. It did get a little bit disrupted by COVID, but we were able to complete the data accrual and the data analysis in spite of the pandemic. Those are good questions.
And it sounded like you decided you were going to collect this data from the beginning. Did you track other cancers as well, or were you using lessons learned from this study to maybe shape system-wide problems? For example, taking a while to get the diagnosis and to start treatment. I wonder if you did something similar, like with breast cancer, a few other cancers, to see if gaps were similar among malignancies or not.
Yeah, so that's a very important question. And the answer is we accumulate the same data on every patient who we treat. I've shown you one study because I wanted to get into the details, but we've studied and published our patients with breast cancer, with Wilms tumor, because we see a lot of those, acute lymphoblastic leukemia, chronic myeloid leukemia, and so on and so forth. So we have a huge number of publications that are reflective of the data analyses that we've done. We don't assume that we're doing okay with any disease, and we did make a commitment to accrue data on literally every single patient who we see. And as I mentioned, we've now seen about 17,000 patients over the decade that our cancer center has been open. So we have a ton of data. We have been fortunate to be able to send medical students and residents and fellows to our cancer center who frankly have done a lot of the in the trenches work, getting the data out of our record systems. We do have an electronic record system and we have paper records. We use the paper records on the wards because we don't always have electricity and we don't always have internet. So we need the paper records, but much of the data is entered into our electronic database, which we initiated in 2013.
Yeah, this is so important. And I'll talk a little bit about what we're doing at VidMec, and I would love to hear from some of the members. For example, like what do we do at K Hospital, the major oncology hospital, that, you know, we need data. Like, how are we doing? We think we're doing a good job, but you don't know unless you analyze the data. You know, unfortunately, we don't have the human resources to collect this. The hospital system doesn't seem to maybe understand or prioritize a registry. So a few of our oncology residents have taken it on themselves to try to track this data in terms of, you know, presentation, was it screening or symptoms, age, time from diagnosis to treatment, you know, specifics about the diagnosis. We're starting off with breast cancer, details about surgery, radiation, systemic therapy, endocrine therapy status in terms of alive and remission or recurrence or death. It's going to take years really to get meaningful data, but I think you need to start somewhere. And so we've decided to start with breast. I hope we can track every patient. That is ideal. So it is quite impressive what you're doing. I would like someone from K Hospital to speak up, because I know there are some of you out there. If someone could be brave and just tell me, what do you guys do at K Hospital? I mean, they are so busy. They see so many patients. I don't think they are tracking everyone, but I wonder if there's some data collection, at least in one disease type, or maybe a percentage of patients. Does anyone want to share what's happening at K Hospital? I think Dr. Long, you're at K Hospital. Do you want to tell us what you guys do there?
Yeah, I'm Dr. Long from K Hospital. So
Yes.
in K Hospital, we only have paper storage. The hospital management software we cannot extract data from that software. So whenever we have a research, we usually go to the storage room for paper medical record, and like fighting somewhere for the record among like thousands of records. And the quality of storage is not very good sometimes. So we usually cannot extract all the data we need, and we usually do follow up by calling the patient with the phone number in the medical record, and sometimes they change the number. Sometimes they some people die and they cannot like answer what is going on with them now. So a lot of patients have lost the follow-up. So that is the very big struggle in doing research in K Hospital.
Yeah.
So those are really good points. And if I could just mention a couple of things, we have the same problem. We also try to track our patients down. One of our research nurses would call the patients who had not come back for routine follow-up. And you, frankly, in Rwanda, you never know whether they didn't come back for follow-up because they're doing fine. And it's a long trip and they don't want to make it because they feel fine, or they died. So tracking them down by phone and talking to the patients and the families is really critical, as you were mentioning. There is one thing that I forgot to mention, and that is that at the very beginning, we created data sheets, usually one piece of paper, one page, that was disease specific. So there's a data sheet just for Hodgkin's, there's a data sheet just for breast, there's a data sheet just for Wilms tumor. And they had the specific things that we wanted to know for that disease. And that prompted our teams to enter the data that we knew ultimately we would want to have on those patients. So I think that was very, very helpful. And we got a grant to update those. So we're now going through the process of updating all the sheets based on what we've learned over the last decade. The other thing I would say is that we were able to hire research assistants who work with our clinical team to write the data down and enter the data. The clinicians are very busy. They can barely get through the day. They have so many patients and we have so few physicians and nurses. So having the research assistants at their side to help with the data, I think was really important. And I don't know whether, that's something that you could afford in your system. We were able to get money to do that in Rwanda, but that was really very helpful.
Yeah, because at least at VidMac, which is very different, it's a private hospital, we don't have anyone to do that. We have a research department, frankly. I'm not sure what they do. Maybe they just provide some guidance, but I don't think they have the resources to actually collect data. So you bring up a good point about grants, right? If you have a question and you want to answer it and you need help, maybe trying to apply for funding to get the people to get the work done. Dr. Long, I know K Hospital does have a research program. I'm just curious in terms of who belongs to this team and what type of research are they doing?
Well, there are two types of research in K Hospital. We have a clinical trial unit, which usually run a part of the big trial, international trial. So they follow the standard protocol of the big trial, and we also do like retrospective and small observational research on our own. And for those research, the doctors at the clinical department will do the research.
Okay. And I know you guys are really busy, so if you want to do research, do you have any time protected to do research, or is it basically you're doing it weekends and evenings if you're motivated?
Sometimes, most of the time we do it like after work or at weekends. But sometimes we plan it before we do it. So during our like consultation or MDT, we record the cases. So we can prospectively collect the data. But most of the research are retrospective, and we go to the storage room to collect the data.
Okay, yeah, thanks. Well, thanks for sharing, Dr. Long, your experience at K Hospital. Anyone else have any experience with clinical research or have questions? Maybe you have an idea you want to study and you want Dr. Schulman's or Larry's help figuring out what to do next.
So I have several questions about like research ideas. Usually in our institution, we do like summarize the efficacy and adverse event of a new treatment that has been applied to our institution, which has been done in developed countries, but we like do the like Me Too research in our hospital. But those research are not very created, not very new knowledge. They just do whatever has been done exactly the same in developed countries. So what other direction, like what other way to think of the research idea, which is new and interesting and is suitable for the resource limited setting, which are the aspect that we can focus on.
Yeah, so that's really, really good question. And obviously when we did the Hodgkin study, ABVD was already 30 years old. It wasn't a new treatment that we were trying. We were using an old treatment to treat our patients. But what we did learn, as I mentioned, was the patients who we saw in Rwanda were very different than the patients we see in Italy or US. And I think that was important for us to understand. But frankly, we're starting at Penn and other US systems to start to look and make sure that the treatments that we're providing are in fact optimal, and that the outcomes are optimal. And so I think there's now more of a focus on the details of cancer care delivery in all settings, high-income countries, resource-constrained countries. And we just did, for instance, a study in the US. We're going to present this at the oncology meetings in June in Chicago, where we looked at breast cancer treatment that across the US, not just at Penn, and found that only 60% of the patients who should have gotten this treatment, which is a treatment that improves the cure rate, actually got it. So, you know, that's not sexy. It's not a new treatment. We're not discovering a new gene, but treatments are only as good as they're administered. And we don't do nearly as well in the US as we would like. We don't do as well in Rwanda as we would like. So we're continuing to try and understand what the barriers are to care. The other thing that we're doing a lot of in the US has to do with disparities of care. You know, the patients who live in rural areas are not doing as well as the patients who live in cities. You know, and what can we do to try to improve that so that the patients who live in rural areas are doing as well as our patients who live in places like Philadelphia? So there are a lot of questions that you could ask that would be specific for your context that I think would be very important to understand.
Thank you.
And I think that, yeah, those are great suggestions. One other thought I had as well is one thing that we could study in a resource limited setting that is not going to happen in the States would be effectiveness of low dose immunotherapy, because I can't imagine they're going to do lower doses when there's a standard dose that's been proven to be effective, but our patients can't afford full dose immunotherapy. Is there benefit in giving 10% of the dose or 50% of the dose? I think that's a really important question. And I know it's been studied in India. I believe there was a study, low dose immunotherapy with head and neck cancer. So I think perhaps most of our studies would be more, okay, we're doing the standard of care that's widely accepted worldwide. How are we doing compared to other countries? But this might be one area can be completely novel. Like, can we use a lower dose? Because I don't think it would be ethical to do it in the States, but maybe it's something that could happen in a resource limited setting where, okay, they can't afford full dose. So let's try 50%. Is that going to be beneficial? So that's something I would love to study. I think it'd be really important.
Yeah, so Kelly, that's also a great point. And we're doing that in Rwanda. And we're doing it with trastuzumab for HER2 positive breast cancer, whereas, you know, the standard of care in the US is a year of trastuzumab. There is some data out there that suggests that 6 months might be as good, but frankly, we can barely afford any trastuzumab. And so we've made a decision that we're going to use 50%. We're going to treat them for 6 months rather than 12 months. And again, we'll follow the outcomes carefully.
Well, that would be interesting because it's a big problem in Vietnam as well. In Can Tho, the Mekong Delta, the southern part of Vietnam, I think only 10% of patients with HER2 positive breast cancer can afford trastuzumab. I think in K Hospital, I've been told it's closer to 30%. So there's, yeah, huge number of patients that don't have access because they can't afford it. So if they can have a lower dose or have it for a shorter duration, perhaps it'll be affordable for them. Do you know, is it going to be on the essential medication list? There's, I think, the ATOM initiative where the WHO and other groups are trying to make, you know, some very important cancer drugs available.
Well, there's a disconnect between what goes on the WHO essential medicines list and what's necessarily available.
Okay.
And I worked with WHO in their essential medicines list from 2017 to 2020. Anyway, 4 years in there somewhere. and we got some drugs like trastuzumab and rituximab added to the list. But they're still not available in a lot of places. And as you suggest, even where they are available, they're not always affordable.
Mhm.
One of the things that we've done in Rwanda, which is a very, very poor country, is that we, through donations, actually supply all of the chemotherapy for free. And so, running out of money is not one of the reasons why the patients did not complete their chemotherapy.
Mhm. Okay, great. So we only have about 5 minutes left. Other questions for Larry?
I have another question on like when we set our research, how do we get everyone to be involved? Like especially like busy clinician, how can we make them to input the patient data? And should we like have a payment system or any motivation for everyone to get involved in the research?
So that's really a terrific question. So I think, I mentioned earlier that we have these data sheets that are disease specific. They actually make it very easy because mostly it's just check marks. You don't have to write ECOG performance status of blah, 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 blah. You just check the box that has the right ECOG performance status and so on and so forth. And so what we've tried to do is make it as easy as possible to get the data. We also have research assistants who can go on rounds and try to help fill out the data forms because everybody is very, very busy. But, I think all of us are invested in doing the best we can, knowing how we're doing, and frankly, also academically publishing it. And as I showed you at the beginning with that paper, our Rwandan colleagues are authors on that paper. A lot of them didn't do the data abstraction, but they took care of the patients. They deserve to be on that paper. And when we go to the World Cancer Congress every other year, this last year was in Geneva, we send our Rwandan colleagues to do the presentations. I have slides of them doing it, and that's important to them. It's important to their careers and how they view the work that they're doing. So they need to be involved. They need to be key members of the team. They need to have their names published. They need to be able to go places to present the data. They're doing the work, but you have to have, the reward at the end of the tunnel, right?
Can you mention the journal that this was published in? Because I think people might have a question. Okay, I write something. Where can I get it published? And so maybe you can share that with the group, suggestions for.
Yes. Yeah. So I will say that I'm happy to look over any studies that you're designing or doing. I'm also happy to advise you on where to publish things. Kelly knows where to find me. But that particular article was published in an ASCO journal, which used to be called the Journal of Global Oncology. It's now called the Journal of Clinical Oncology-Global Oncology. So it changed its name about a year or so ago. But I helped ASCO to form that journal, I don't know, maybe 6 or 7 years ago. And that journal is entirely devoted to studies that come out of places like Vietnam or Rwanda or Haiti or other places that we work. And if you look at that journal, all the articles are from places like what we're talking about. And they're very, very anxious to help with that. They have a mentorship program, so they have experienced authors who are willing to work with you to help with the manuscripts. And there is it is an open access journal, so there is a manuscript fee, but that fee is structured depending on the country. So it's full fee if it's coming from the US. If it's coming from Rwanda, it's basically free. So we're working very, very hard to encourage people like you to write up what you're doing and to submit it. But again, I'm very happy to help. I'm on their editorial board. So I review a lot of the manuscripts, and the editor-in-chief is somebody named Gilberto Lopes, who is now at the University of Miami, but he's Brazilian and grew up in sort of a middle-income country, probably not a lot different than Vietnam, where there's a lot of variability in the resources that are available to patients. And Gilberto is great, and he's been a terrific supporter of programs like yours.
Great. Well, I think that's very helpful, and it's past the hour, so I think that's a perfect note to finish on. And thank you so much for getting to work early to speak with us, and I think very useful. If anyone has any questions that they think of later, just email them to me and I'll pass them on. And Larry had said he's willing to talk to our group again. So if you have any suggestions on topics you'd like him to cover, please share it on the Facebook page or send me a message. So again, I want to thank you for your time. I think we all learned a lot and really appreciate it.
Thanks so much for being with me this morning. Great to see all of you.
Okay. Take care. Have a great day.
Thank you so much.